The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hey, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. Doing something different again this week. This is a lecture that I did for my students, my nursing students, on congenital heart defects. I haven't shared any of my lectures as a podcast episode before, but this is one that I'm recording in advance and there aren't any students involved. You know, sometimes the students will speak up and say personal things or things about their family that I wouldn't want included in any kind of podcast, and maybe I speak a little more loosely with a familiar group like that than I would just for the general public, but I thought maybe this would work as an overlapping thing. So here's my lecture on congenital heart defects. I hope you enjoy it. Congenital heart defects, as the name kind of implies or suggests, these are structural defects in the heart that happen due to abnormal development of the fetus. These are things that are present at birth, right? So when you hear anything that's congenital versus acquired, in general, that means congenital is it happens during development, you're born with it. Acquired means it happens later in life for whatever reason. So because these are defects that are present at birth, we're mostly going to be talking about children. Hopefully, most of these things get picked up when a person is born, is an infant, or in early childhood before they end up causing problems. And a lot of these things, as you'll see, are so bad that there's no way you can not pick it up almost during childhood. There are some things that persist into adulthood that people don't know about. The main one I'm thinking about would be PFO, patent foraminovaly, that can be a cause of stroke in older people. And sometimes that people make it into later life without knowing they have that, and it gets picked up on an echo because they had a stroke. But in general, these big major heart defects, these are things that are going to be caught around the time a person's born. So as far as the exam questions you're going to see from this, I would say focus on clinical signs, clinical presentations, treatments, like what do we actually do as nurses for these disorders? Those are the kinds of questions we want you to be able to answer about this content. Any kind of congenital heart defect may lead to heart failure. As you can imagine, if the heart is hooked up wrong, if there's something wrong with it, it is going to stress it in ways that it would not normally be stressed, and that leads to heart failure down the road. Once you're talking about heart failure, whether it's a child or an adult, it's kind of the same thing. It's the same process, same treatments, etc. So I'm not going to talk so much about heart failure as just the underlying defects that lead to it in this realm. Here's where you can find this information that I'm working from in your concept view on Course Point. There's not a lot in your Nurse Think books about congenital heart defects. I didn't find a case study to go over in there, so I do have some case studies at the end that are taken just from YouTube from various sources, so we'll go over that at the end of this lecture. Just to review kind of the normal circulation, I think it's really key to understand how this works in order to understand what happens when it gets messed up. So in the picture here, we're kind of divided into right and left sides. You know, as you're facing the patient, it's the patient's right and left we're talking about. So in this picture, what we think of as the right side is on your left as you look at the picture, and what we think of as the left side is on your right. But of course, we're talking about the patient's left and right. So the right side of the heart receives oxygen depleted blood from the body. That's via the superior and inferior vena cava. That enters into the right atrium, flows into the right ventricle, then it goes out through the pulmonary artery to the lungs, where it's oxygenated, comes back through the pulmonary vein into the left atrium, down into the left ventricle, and then out through the aorta to the rest of the body, where it does its thing, and then it comes back. So that's our cycle that we think about as being normal. That's the way the plumbing should be hooked up. This is the way it should work. It's a good idea to be able to picture all this in your head when we're talking about, oh, this vessel's hooked up wrong. These things are transposed, or this is hooked up to the left side when it should be hooked up to the right side. If you understand this picture and how this works, you should be able to figure out what the issue is with these defects we're going to talk about. So the right side of the heart's job is to pump blood to the lungs. The left side's job is to pump blood out to the rest of the body. The right side should be a much lower pressure system. We're talking about veins, not arteries. And if you think about what a normal like PA pressure is, for example, it's way, way, way lower than the systemic blood pressure, right? So that's why the right side of the heart is smaller, right? That's why we mostly worry about the left side of the heart when we're talking about acute cardiac issues, because the left side of the heart is bigger. It has to pump against the systemic blood pressure. So when you think right side, you should think low pressure, and you can generally think venous. Obviously, the pulmonary artery is named the pulmonary artery because it carries blood away from the heart, even though you would kind of think of that as being deoxygenated, quote unquote, venous blood. So there's a one little exception to the rule there. And then on the left side of the heart, you should be thinking high pressure and arteries, except for, of course, the pulmonary vein is named that because it brings blood into the heart, even though it's oxygenated blood that we would tend to think of with an arterial system. But it's really helpful to think about high pressure versus low pressure, because just like any liquid in any system, blood is going to flow from areas of higher pressure to areas of lower pressure. And these congenital heart defects involve abnormal connections between the left side and the right side. So it's helpful to think about which way the blood is going to flow if there's an abnormal connection, and then what are the downstream consequences of that going to be. It gets a little confusing when the pipes aren't connected the way they should be, and then it kind of changes your thinking about which side's left and right and which is high and low pressure. But in general, if you can think like there's higher pressure on this side, there's lower pressure on this side, and there's an abnormal connection here, the blood's going to be going from high to low pressure. So that can be kind of helpful in thinking about which direction the blood's going and what that's going to cause. You don't have to memorize these numbers or anything. This is just a little graphic to illustrate the point that the pressure and the oxygen saturation on the right side of the heart are way lower than the pressure and the oxygen saturation on, I may have just said that backwards. The pressure and O2 saturation on the right side of the heart are way lower than the pressure and oxygen saturation on the left side of the heart, right? You should have low pressure, deoxygenated blood on the right side. You should have higher pressure, oxygenated blood on the left side. And what's the saying? The twain shall never meet. They should be separated. There should be barriers to keep the left side and the right side separated. The only places they should cross over are in the capillaries in the lungs and the capillaries out in the peripheral tissue. Fetal circulation is different than adult circulation, right? Because the baby is inside the womb. It's not breathing air, and yet it still needs oxygenated blood. Well, how do we do that? We connect the pipes a little bit differently so that mom is providing the oxygenated blood for the baby. So what we need to have is the lungs be bypassed. There's no need to send a bunch of blood to the baby's lungs while in utero, because there's nothing happening right there, right? There's no oxygen getting to those lungs. So what we need to do is have the lungs bypassed until the kid is born, and then we need to switch over to being able to breathe air and oxygenate as an adult would. So during fetal circulation, during the fetal period, the pressures are kind of reversed, right? The right side is actually the higher pressure side until the baby is born, and then it shifts to what we think of as normal circulation. It takes a while for that shift to occur. So the pulmonary vascular resistance, which we think of as the pressure on the right side of the system, is still higher in newborns for a while, normal newborns. And so for that reason, sometimes it can take some of these defects a little while to show up because we expect a little bit higher pressure on the right side for a while until we completely transition over from fetal to non-fetal circulation, I guess is a good way to say that. So remember that the baby is hooked up to the mom through the umbilical cord. So the blood comes from the placenta and goes back to the placenta through that umbilical cord that contains the umbilical arteries and the umbilical vein. And again, remember we define arteries and veins by which way they take blood from or to the heart. And in this case, we're talking about the fetus's heart. So umbilical arteries means they're carrying blood away from the fetal heart, which would be deoxygenated blood. The umbilical vein is carrying blood back to the fetal heart, which would be oxygenated blood from the placenta. I already mentioned the foramen ovale. It's circled in red here. So here's the connection between the two atria. So the right atrium and the left atrium have a wall between them. The foramen ovale is a hole in that wall that allows blood to get from the right side to the left side without going through the lungs. So think about the blood coming back from the placenta into the right atrium, just like it does in non-fetal circulation, right? All the blood comes back from the body into the right atrium. Normally, it would go to the right ventricle, up into the pulmonary artery, and then to the lungs. But we don't want it to go to the lungs in this situation, right? So we take down the wall between the right atrium and the left atrium that allows blood to go straight from the right side of the heart to the left side of the heart. And then the other connection is called the ductus arteriosus. This connects the pulmonary artery and the aorta. So remember, the pulmonary artery would normally be carrying deoxygenated blood. The aorta would normally be carrying oxygenated blood. Here's the other place where we connect the left and the right side. So the blood has two opportunities to make it from the right side of the heart to the left side of the heart without going through the lungs. That's the foramen ovale between the right and left atrium and the ductus arteriosus that connects the pulmonary artery with the aorta. Try not to get lost in all the terms here. Still, what we're talking about is just connecting the left side to the right side and bypassing the lungs. That's the goal here in fetal circulation. Both of these things should close shortly after birth. So baby's born, right, starts breathing. These two holes need to close up pretty quickly so that we can get the blood going to the lungs where it's supposed to be and get started on the non-fetal circulation. So if those things remain open, that's going to be a problem in most cases. There are some situations where those things need to remain open until we can fix some other defect, and we'll get to those in a second. So what causes congenital heart disease? Familial predisposition. If you have family members that have aortic or pulmonic stenosis, so that means stenosis of the aortic valve or the pulmonic valve, atrial septal defects, tetralogy of Fallot, we'll talk about what that is later, and ventricular septal defects. Those are not genetic abnormalities per se, but they can kind of run in families. You can have a predisposition to that based on family history. So if that's something that runs in a kid's family, that would be something that they're going to look for more closely with ultrasounds and whatnot during fetal development. The actual genetic abnormalities we think of, like Edwards syndrome, which is trisomy 18, Down syndromes, trisomy 21, Turner syndrome or Williams syndrome, all of these can have and commonly do have heart defects associated with them. And then, of course, there are risk factors that we would consider modifiable for congenital heart defects. These are like things that are teratogenic. So teratogenic means it causes birth defects. I guess the big example that everyone thinks of would be thalidomide. the medication. I want to say this was back in the 60s, 70s that we thought it was fine to take while you're pregnant, but it turns out it really was not fine and caused all these crazy birth defects. And we have to be that's why we have to be really careful about giving medicine to pregnant people, because they can have effects on fetal development. So any kind of substance or influence that can be teratogenic can lead to development of congenital heart defects. Febrile illness, right? If mom gets really sick during the pregnancy and has high fever, that can cause congenital heart defect in the kid. Diabetes makes congenital heart defects more likely. Drinking alcohol while you're pregnant. Lupus. Some prescription medications, specifically some of the anticonvulsants and lithium. And folic acid deficiency. Of course, with folic acid deficiency, mostly what we think about is neural tube defects, so things that are going to affect the nervous system. But deficiency of folic acid can also cause heart defects as well. So the way we classify congenital heart defects is kind of by which way the shunting goes. Is it left to right or is it right to left? And then whether it is cyanotic or acyanotic. So in the first case, we're talking about, remember we said that the blood is going to flow from high pressure to low pressure. So whether that means it's going from the right side to the left side or the left side to the right side, you can classify the specific heart defect by that, or you can classify it by whether or not they cause cyanosis in the patient or not. And that's literally like, is there cyanosis? Are they blue when you look at them when they have this defect? So what causes cyanosis? That's deoxygenated blood, right? That means too much deoxygenated blood is reaching the peripheral tissue. And that's what causes cyanosis. So things that are right to left shunts tend to cause cyanosis. So remember, that means they're bypassing the lungs, right? They're going straight from the right side of the heart to the left side of the heart without making it to the lungs. So you have too much deoxygenated blood going out to the rest of the body through the left side of the heart. Tetralogy of Fallot is classified as a cyanotic heart disease or heart defect. Transposition of great vessels, and then only having one ventricle. If you only have one ventricle, that's pumping blood to both the lungs and out to the rest of the body. So, and we'll talk about what transposition and tetralogy of Fallot are specifically in a little bit. The other heart defects would be classified as acyanotic because, as the name suggests, they do not cause cyanosis. And then another way you can classify these is by whether or not they disrupt the pulmonary blood flow. So if you're not sending blood to the lungs, you're going to see a lot of fatigue, a lot of difficulty breathing, and a lot of failure to thrive in these infants, these these infants and children. So a defect that decreases the blood flow to the lungs, that's going to be a right to left shunt. So these things are classified in multiple, like the same heart defect can be classified in multiple ways, right? So if it disrupts the flow of blood to the lungs, that means it is a right to left shunt. Also, let me go back a little bit. No, yeah, that's fine. Okay. So right to left shunts are the defects that decrease blood flow to the lungs. That's correct. So pulmonary stenosis, tetralogy of Fallot, transposition of the great vessels. You can also have a problem that sends too much blood to the lungs. So remember that the right side of the heart that deals with the lungs, those vessels are designed to be low pressure vessels, right? They're not designed to handle all of the blood. So if you have a defect that sends too much blood to those vessels and the pressure is too high in the lungs, that can cause a problem just as well as low pressure can. The way that the pulmonary vasculature is going to respond to too much pressure is with vasoconstriction to try to shut that pressure down. And over time, the vessels can actually remodel themselves. So that's going to increase the pulmonary vascular resistance and further decrease the amount of blood flow to the lungs. So badness in the short term and badness in the long term. So things that cause increased blood flow to the lungs would be ventricular septal defects. So if you think about that in an otherwise normal heart, if you tear down the wall between the two ventricles, which way is the blood going? It's high pressure to low pressure, right? So it's going to go from the left ventricle into the right ventricle and then into the lungs. Same thing if the wall is torn down between the two atria, or patent ductus arteriosus. So remember we talked about the ductus arteriosus is the connection between the aorta and the pulmonary artery. So in an otherwise normally hooked up heart, the pressure in the aorta is a lot higher than the pressure in the pulmonary artery. So if that ductus arteriosus remains open, if you leave that hole there, which way is the blood flowing? It's going from high pressure to low pressure. So it's going to come from the aorta back into the pulmonary artery, go to the lungs. And so over time, of course, that can lead to heart failure because you've got the right side trying to pump against more pressure than it's designed for. Respiratory infections, endocarditis. None of that sounds very good. Okay, we'll go through and talk about some specific defects now. So an atrial septal defect is exactly what it sounds like, a defect in the atrial septum. So there's some kind of hole in the wall between the two atria. I already talked about the patent foramen ovale, or you'll hear it called PFO. That can be one that lingers into adulthood and ends up causing strokes, and that's kind of the way you find it. Typically, this is going to create a left to right shunt, right? Because assuming everything else is hooked up correctly, the pressure on the left side is a lot higher than the pressure on the right side. So if there's a hole between the two atria, the blood's going from the left side back to the right side. So that increases blood flow to the lungs. One clinical sign of this that you can pick up is it's called a split S2 heart sound. So it takes longer for that pulmonic valve to close because there's too much pressure in there, right? So, normally with our normal heart sounds, we call S1, S2, right? Loved up, loved up, loved up. So if the valves that create the S2 heart sound are not closing at the same time, it's going to split the sound. So instead of loved up, loved up, loved up, you have loved it up, loved it up, loved it up. So it's called a split S2. And that can be a normal finding, or it can be an indication of something like this, a heart defect. And then, of course, as I mentioned before, you're going to have a higher risk of pulmonary vascular disease down the line if you have any kind of left to right shunt, including these atrial septal defects. This is not a cyanotic heart defect, so no cyanosis associated with atrial septal defect. You can kind of use the patent foramen ovale as your example there, right? If you can make it into adulthood and nobody notices that you have this, obviously it's not something that's going to be causing cyanosis. Sometimes they don't always go in and close these. If it's a small asymptomatic deal, even if they do pick it up during childhood, it's not necessarily something that has to be fixed. A lot of times they will kind of repair themselves over time. If a kid makes it to 8 years old and still has this atrial septal defect, sorry, my A word's talking to me. Thunderstorm warning. Uh-oh. If a kid makes it to 8 years old and still has this defect, then that means it's unlikely to close spontaneously. And after that point, they start talking about surgery to prevent long-term complications. The way these are diagnosed, of course, ideally it's picked up on an echo, an ultrasound, even before the kid's born. Ideally, these are present in the womb, right? Because you can certainly see the baby's heart beating with an ultrasound while they're in utero. After they're born, you could potentially hear a heart murmur. If you're working with newborns and little kids, you want to be good at heart murmurs because you may well be the person who put your stethoscope on that kid's chest and picks up on a heart murmur that nobody else has heard before. So Especially, I think we all ought to be proficient with hearing heart murmurs, but especially if you're working with newborns and little kids, it's important to carry that stethoscope around and listen to your patient's heart like you're supposed to, because you might actually pick up on something that nobody else has noticed. Sometimes on a chest X-ray, you can see that the heart is enlarged if we make it to the point where the heart is being affected by pumping against the wrong kind of pressure all the time. And then an echocardiogram of the kid after they're born, right, is really the definitive way to diagnose not just atrial septal defects, but any of these heart defects. Anytime we're talking about things hooked up wrong, valves not working right, anything structurally wrong with the heart, the way to look at that is with an echocardiogram, which is an ultrasound of the heart. So that's atrial septal defects. Now, ventricular septal defects. So same thing, except it's happening in the ventricles, right? It's a hole between the wall that separates the left and right ventricles. This is the most common type, actually, of congenital heart disease. Of course, that's going to allow blood flow to go between the two ventricles. And which way is it going to go? Well, if everything else is hooked up right, the left side is much higher pressure, so that blood's going to go from left to right. So it's going to create a left to right shunt. Not a cyanotic heart defect. You will not see cyanosis in these people. How big that defect is what's going to determine complications and how severe this is, right? Over time, of course, if we get the typical left to right shunt, that's going to increase the pressure on the right side of the heart, increase the pressure on the lungs, and over time that leads to increased pulmonary vascular resistance. Over time, just like, if you have somebody with hypertension and the left side of the heart is having to pump against that hypertension for their whole lives, eventually that it's going to get big, right? Like any other muscle, that left side of the heart is going to get too big. And then we have left ventricular hypertrophy, which leads to heart failure. Well, the same thing happens on the right side, right? If the right side's pumping against too much pressure for a long time, it's going to get bigger. And you can actually have a situation with a VSD like this, ventricular septal defect, where if it's not corrected, it can turn into a right to left shunt. So if the peripheral vascular resistance gets so high that it's higher than the systemic vascular resistance, in other words, the pressure on the right is now greater than the pressure on the left, well, the blood's going to flow back the other way. So this left to right shunt can eventually turn into a right to left shunt if it's not addressed. That's not confusing at all, right? Very much like atrial septal defects, these, if they're very small, very asymptomatic, then they might just leave it alone and watch it. Obviously, if it's a big defect with a bunch of clinical symptoms, then they're going to have to do something and close it. All right, patent ductus arteriosus. So with this, I'm going to go ahead and tell you, this patent ductus arteriosus, the foramen ovale, there are going to be several questions on your test about seeing if you understand what the ductus arteriosus does and how we keep it open or how we close it, when it should stay open, when it should close. So I want you to understand this. I want you to really understand what it means when the ductus arteriosus is open, when do we want it open, and when do we need it to close. Whatever time you spend studying this information, you should probably spend mostly on this area. So recall, the ductus arteriosus is the connection between the aorta and the pulmonary artery. It's normal in fetal circulation, right? When the baby's still inside the mom, we need that to be connected, so we bypass the lungs. When the baby's born, it should close up so that the blood now goes to the lungs and we start breathing and having normal post-fetal circulation. Is that even a word, post-fetal? I don't know. And so if you think about it, the stimulus to close the ductus arteriosus is when oxygen hits it, right? When the baby starts breathing, suddenly we've got oxygen coming into the lungs. There's more oxygenated blood going past that ductus arteriosus, or through the ductus arteriosus, really. That oxygen is the stimulus for that to close up. So initially it's just a muscular constriction. The hole, the tube, the ductus arteriosus senses that oxygen. It goes, oh, we got to close. Whoop, and it constricts, closes. It's fully closed within 48 hours of the baby beginning to breathe. And then it's permanently closed with fibrotic tissue by the time the kid is 2 to 3 weeks old, or 2 to 3 weeks after birth, I should say. And eventually that becomes a structure called the ligamentum arteriosum. So if you're looking at adult anatomy, you will see a structure called the ligamentum arteriosum between the aorta and pulmonary artery. That's where the ductus arteriosus used to be. So while that ductus is open, it allows blood from the aorta and the pulmonary artery to mix. And if it stays open after birth, then that's a problem, right? If it does not close, we call it a patent ductus arteriosus, and then it's a problem. How bad it is, of course, depends on how big it is, right? Is it only open a little bit, or is it widely patent? That obviously is going to affect how much blood is able to flow through there. And then the pressures. So if everything else is hooked up right, I should say if everything else is hooked up correctly, the pressure in the aorta should be a lot greater than the pressure in the pulmonary artery. So the blood's flowing from high pressure to low pressure. So you're having a left to right shunt, correct? Again, assuming everything else is hooked up correctly. This is not a cyanotic heart defect. So you will not see cyanosis in these patients. It can lead to heart failure, like all these other things. Increased pulmonary vascular resistance, like the other left-right shunts we've talked about, can lead to aneurysms and clots. These pretty much have to be closed. If you have a patent ductus arteriosus, I'll say PDA, that's what I'm talking about. Pretty much they have to close that. That's not something you can just kind of let it ride. The way we close them, first line would be oxygen, right? Because oxygen's supposed to close them. So sometimes you can just give the patient a little bit of extra oxygen and that will stimulate it to close. About 80% of them can be closed with NSAIDs, right? Non-steroidal anti-inflammatory drugs. Typically the one we're going to use for that is called indomethacin. So this is not one you typically buy over the counter for joint pain, right? But indomethacin is an NSAID, just like those kind of medicines, ibuprofen and naproxen, and the prescription ones like meloxicam and celecoxib, all very common medicines. Indomethacin also is traditionally used for gout for whatever reason, but it's an NSAID, right? So that NSAID is going to stimulate the ductus arteriosus to close. If there's a situation where we need to keep it open, and we'll talk about that a little bit later. So if other things are hooked up incorrectly and you need to keep that open to keep blood flowing, you can actually use a prostaglandin to keep it open. And the typical one is called alprostadil. That giving that to the patient keeps the ductus arteriosus open. Okay, you want to know this, all right? NSAIDs and oxygen close the ductus arteriosus. Prostaglandins like alprostadil keep the ductus arteriosus open. So there are some of these congenital heart issues where everything else is hooked up goofy, and so you need that connection between the left and right side, because that may be the only connection between the left and right side. So in those cases, we do not want that to close, because that's the only way we're getting any blood flow out to the tissue. So in those situations, you want to give prostaglandin, and you do not want to give NSAID when you want the ductus arteriosus to stay open. But if it's just a patent ductus arteriosus by itself, that's the only defect. We do want to close it, so we want to give them oxygen and NSAIDs like indomethacin. If you happen to be one of those 80% of people who the NSAID did not close your ductus arteriosus, then you need to have a surgical procedure to close it. Please understand all of that. If you have any questions about it, be sure to let me know. Okay, pulmonary stenosis. So this is where the transition between the right ventricle and the pulmonary artery is very stenotic, so it's very small, a lot smaller than it should be. So this obstructs the blood flow between the right side of the heart and the lungs, right? It can happen in the valve. Usually when we talk about pulmonic stenosis, aortic stenosis, mitral stenosis, whatever. We're talking about the actual valve. This can happen at the valve, or it can happen in other areas, but anywhere around there in that neighborhood can be stenotic. So it's too tight to allow the blood, or at least to allow enough blood to get out of the right ventricle. This often happens in correlation with other heart defects, so this can also often be part of other syndromes or collections of defects. This does create cyanosis, right? Obviously, if you can't not get blood to the lungs, it's not going to get oxygenated. So this is a cyanotic heart defect, and it can create a right to left shunt, meaning the right side of the pressure on the right side of the heart is going to be greater than the left side. Obviously, there's going to have to be some other connection in order for blood to get from one side to the other. And this is a situation where we may want that ductus arteriosus to stay open, right? So let's say that everything else here is hooked up correctly, and you just have this very stenotic pulmonic outflow tract where blood cannot squeeze through. How else is it going to get out to the body? Well, we need that connection up that would be up here, right, between the aorta and the pulmonary artery, because this is a loop, remember, and so the only way that blood's going to be able to cross between left and right is through that ductus arteriosus, if you have a very severe stenosis here. So this is a situation where we might want to give, say it with me, prostaglandin, like alprostadil, to keep the ductus arteriosus patent until they can fix the stenosis. All right, tetralogy of Fallot. This is a cyanotic heart defect. In fact, the most common cyanotic congenital heart defect. The prefix tetra means 4, so there are 4 defects associated with that, with the tetralogy of Fallot. Ventricular septal defect, which we already talked about. An overriding aorta. So this means where the aorta connects to the left ventricle, it kind of like is too big. There's too much space there. There's too big of a hole, and so it kind of overrides the right ventricle as well. Remember that we have an abnormal connection between the two ventricles already, so you have a hole in the wall, right, between the two ventricles, and then you also have the aorta, which is too big and kind of overrides that defect. So, my goodness. So essentially, you have it's sort of like you have one big ventricle. Not quite. That is a separate abnormality, but in practice, there's big communications here that sort of kind of make it one big ventricle. So those are 2. The third defect is obstruction of the pulmonary artery, or stenosis of the pulmonary artery. So we talked about that specifically in the last slide. So this happens often as a part of this tetralogy of Fallot. And then you have right ventricular hypertrophy because of the obstruction of the pulmonary artery. So this should make sense, right? There's too much pressure in the pulmonary artery, or there's not enough blood flow going into the pulmonary artery. So the blood's got to go somewhere. So in this case, it's flowing across the ventricular septal defect and up into the aorta. So essentially, we're bypassing the lungs again, which is not great. So because we're bypassing the lungs, this is going to cause cyanosis. So this is a cyanotic heart defect. If you just look and see which way the blood is going, this is creating a right to left shunt. So those are 2 ways to classify tetralogy of Fallot. Kids with this situation tend to get worse during times of stress. They have these things that are called TET spells, where they kind of like turn blue and have trouble breathing. So in infants, really anything that creates an increased oxygen demand can cause one of these TET spells. So that in a little baby, we're talking about crying, feeding, pooping. They don't really do much else, right? So anything that stresses them like that can kind of cause increased oxygen demand and exacerbate one of these spells. In older infants, they will turn blue. They'll be working harder to breathe, and we've talked before about what kind of symptoms we look for or signs we look for in infants to see what their work of breathing is like. They become more irritable. They can sweat, right? They can become diaphoretic. They can become limp. They can actually pass out, as you would expect, right, if they're not getting enough oxygen to their brain. There's a way that we can address this clinically if we know we're dealing with one of these infants and they have a TET spell. We shove their knees up into their chest. We put them in knee-chest position. And what in the world does that do? Well, it increases the systemic vascular resistance. So remember, we have a situation where the pressure on the right side is too high, so the blood's going from right to left. If you pull the knees up to the chest, if you increase the resistance, right, that makes it harder to get blood into the lungs, right? If you're shoving if you're bending the knees and pushing them up into the chest, that's making it a lot harder to get blood down into the lungs. You're increasing the pressure on the left side, and you're correcting the pressure differential there. So we're encouraging blood to go back from the left side to the right side where it should be. If it's an older child, if it's a toddler or an older kid, they will kind of do this on their own. They will actually squat down. So they're putting themselves in knee-chest position. I'm going to assume that that's just a person's natural response to feeling however you feel when you're about to pass out because you don't have enough blood flow. I'm assuming that these toddlers and children don't innately understand the anatomy of the heart and how theirs is hooked up backwards. But, well, I guess it's not backwards. How theirs is hooked up wrong, how theirs is defective. I assume that's just a natural human response to feeling like you're about to pass out. But when they do squat down like that, it's the same thing as us putting them in knee-chest position. It increases the systemic vascular resistance and helps to correct the underlying problem with the pressure. Some other things we can do to help decrease the myocardial oxygen demand would be to give morphine or to give oxygen to the patient. So there are a couple of other things that we can do as far as interventions. And this is something that has to be fixed. It may not be fixed immediately after birth, but as you can imagine, with this level of defect, this much stuff going on, that is going to have to be fixed at some point. Whenever we are chronically hypoxic, whenever we're not getting enough oxygen, like long term, how do you think the body would respond to that? Well, what carries the oxygen around is the blood. So one way that the body can try to compensate for not having enough oxygen in the blood is to try to kind of make more blood. So you see the situation where you have polycythemia, which means an increased number of red blood cells, which causes increased hemoglobin and hematocrit if you're looking at like a CBC. So the RBCs, hemoglobin, hematocrit, all elevated. That's the bone marrow trying to help out. That's the bone marrow going, hey, there's not enough oxygen getting around. Maybe I could crank out some more blood cells and we could carry more oxygen and that would help the situation, which is fine. But when you have polycythemia like that, of course, your blood, we say it's too thick, right? Quote unquote. And when that happens, those patients are a lot more prone to getting blood clots, which can turn into strokes and heart attacks and whatnot. So it makes sense that would be the compensatory mechanism, but then that kind of becomes a problem as well when it's taken to extremes. When we're assessing these infants, when we're caring for these infants, we always want to use their right hand for our pulse ox sensor. Why would that be? I think this is super duper interesting. If you look at, I'm going to scroll back a few slides here. If you look at where the ductus arteriosus is, it's not a great picture. It's kind of in this neighborhood, right? Between the aorta and the pulmonary artery. Well, what are these vessels that come off the top of the aorta? Those are the things that lead to the subclavian arteries, the carotids, all that stuff comes off of the aortic arch right there. The vessels that supply blood flow to the right arm are before the ductus arteriosus, whereas the vessels that supply blood to the left arm are after the ductus arteriosus. So your best chance of getting an accurate oxygen saturation are going to be in the right arm, because if something's up with that ductus arteriosus, if it's closed when it shouldn't be or it's open when it shouldn't be, that's going to affect everything downstream. So we have a better chance of getting an accurate oxygen saturation if we use the right arm. And that's true for any congenital heart defect, by the way. And so one way that we could potentially pick up a congenital heart defect is comparing the oxygen saturation in the right arm with the left arm and seeing if it's different. In a situation where we need increased blood flow to the lungs, like this situation, right? There's too much going from the right side to the left side. What else can we do to increase blood flow to the lungs? We can keep that ductus arteriosus open. So this is a situation where we might need that ductus arteriosus to stay open, which means we would want to give the patient, say it with me, prostaglandins, for example, alprostadil, in order to keep that ductus patient, in order to keep that ductus patent. We do want it to be patient about closing for the patient, but we want to keep it patent. And we would not so much want to give them what? NSAIDs. What about oxygen? Oxygen makes that close. Also, there's a dilemma there. They might need oxygen, but the oxygen might hamper or encourage the closing of the ductus arteriosus, which we would not want. Another thing that prostaglandins do, right? We give prostaglandins to keep the ductus arteriosus open. Those also help inhibit platelet aggregation. So if you have a situation where the patient has polycythemia as a compensatory mechanism for the chronic hypoxia, the prostaglandins might also help prevent blood clots. So in the picture there, you see somebody is doing this knee-chest position, right? I don't know if this is a child that has tetralogy of Fallot, but this is what we're talking about. Knee-chest position, take the legs, bend them, push the knees up toward the chest. And that is a good treatment for an infant that is having a TET spell. Okay. Transposition of great vessels. This is what it sounds like. The two great vessels, the aorta and the pulmonary artery, are hooked up backwards. So the aorta is hooked up to the right ventricle and the pulmonary artery is hooked up to the left ventricle. So let's go back to our blood flow through the heart and think about what would happen there. You got blood flow, you got blood coming from the superior and inferior vena cava into the right atrium, down into the right ventricle. Should be going out through the pulmonary artery, but in this case, it's going out through the aorta. So it's going out to the aorta to the rest of the body. Did we skip some things there? Indeed, we skipped the lungs, right? So we're totally bypassing the lungs in this situation. So if you don't have some connection between the right side and the left side, this is totally not compatible with life. Because there's no way for the blood to ever be oxygenated. You create a big circle that totally leaves out the lungs. Obviously, that's a problem. This is most certainly a cyanotic heart defect. And in this case, the patient surviving actually depends on them having a connection between the left and right side. So either that's an atrial septal defect, a ventricular septal defect, or a patent ductus arteriosus. Those are the ways that we can get blood from the right side to the left side and vice versa. So if you have transposition of the great vessels, in order to survive long enough to get it fixed, you're going to have some kind of connection between the right and left side, because otherwise you have no connection. So we need either an atrial septal defect, a ventricular septal defect, or a patent ductus arteriosus. Which one of those can we actually affect and have something to do with? That would be the ductus arteriosus, right? We're not going to go in there and poke a hole in their heart. We're going to give what? Say it with me. Prostaglandins like alprostadil to keep the ductus arteriosus patent open until this can be fixed surgically. Coarctation of the aorta. This is just a very narrow spot in the aorta. This may be either before the ductus arteriosus or after the ductus arteriosus. And so in the situation, Whether it's before or after the ductus arteriosus kind of determines whether or not we want to try to keep that ductus arteriosus open. If you close the ductus arteriosus, that could make the problem worse, right? Because whatever blood was going out through the ductus arteriosus is now stuck in the aorta, and there's this real narrow spot in there that it can't get past. So that could make the situation worse. So these are patients who may also be receiving, say it with me, prostaglandins like alprostadil to keep the ductus arteriosus open. If the ductus arteriosus needs to stay open, we do not want to give them, say it with me, NSAIDs like indomethacin. And so you have this situation where the pulses in the arms and legs will be different. Remember, the circulation to the arms comes off of these three little branches of the aorta that are in the arch right here. So you can see how if there's a little, I'm going to call it a kink, a narrow spot, a stenosis of the aorta after those vessels, you're going to have banging pulses in the arms, higher blood pressures in the arms, but there's no blood or very little blood going beyond that. So you're not going to have as strong pulses in the legs. You're not going to have as high blood pressure in the legs compared to the arms. If you have a situation where there's too much blood going up through these branches of the aorta, remember that's not only the circulation to the arms, but to the head, to the brain. So these people can get headaches, vertigo, start having nosebleeds, irritability in infants. That's such a non-specific symptom, right? Oh, they're irritable. They must have coarctation of the aorta. Not so much. Just like we think about with claudication, people that have peripheral artery disease, in this situation, there's less blood flow going to the lungs. So any kind of there's less blood flow going to the legs. So any kind of physical activity is liable to cause leg pain, right? Because those muscles can't get enough blood flow when they need it. And if we're putting more pressure on this vessel, on the aorta, there's going to be more risk of an aortic aneurysm or rupture because of the higher pressure there. Okay. Hopefully all that makes some sense to you. What are we going to do for patients that have congenital heart disease? If there is hypoxia or they need respiratory support, obviously we can do something about that. We can give them oxygen. We can support respirations if we have to be more aggressive with that. Remember, for TET spells, we want to put them in the knee-chest position. So they're for patients with tetralogy of Fallot. What about if we have the opposite problem, the coarctation of the aorta, where there's too much blood going up into the head? How do we want to position the patient, you think? Right, head up, right? You can keep their head elevated, and that will do a little bit to use gravity to help make it a little more difficult for too much blood to get up into the head. Obviously, adequate nutrition, that would be true for just about anybody. Feeding is one of the most stressful things for an infant. It stresses their heart a lot. So we want to feed these babies really slowly so they're not overexerting themselves. We want to keep them in an upright position. We want to give small, frequent meals, right? We don't want to stress them too much. So smaller meals better than larger meals, which is going to mean they need feeding more frequently. It's good if we can not stress them. So, when it's time to eat or when they very first start showing signs of hunger and crying, feed them. So you don't want them freaking out because they're hungry for a long time. We want to burp them very frequently, like after each ounce of milk or formula or whatever they're getting. We want to give them a high-calorie, iron-rich formula. Just like we've talked about with shock and burns and anything like this where the body's having to work harder all the time. We need more nutrients to make that happen. We need more calories. We need better nutrition to make sure we're keeping up with demands, or else we start breaking down our own tissue for energy. So high-calorie, iron-rich formula if they're not getting breast milk. If they can't tolerate oral feedings, they might end up on tube feedings, of course. And then if this is a patient that is actually being treated for heart failure, what do you think about doing for an adult with heart failure? One of the big things would be diuretics, right? So that's also true for infants. So if they're getting diuretics, of course, we have to pay attention to our electrolytes, primarily potassium. And remember, different diuretics can affect that in different ways. So you want to know which ones are being used. In kids that do have cyanotic heart defects, keeping them well hydrated is especially important. If they have heart failure, if they have systemic hypertension, what do we think about? What kind of diet do we think about for adults that have hypertension, heart disease? Low sodium, right? So they may need a low sodium diet. Obviously, we don't want them to get sick, so we want to monitor real closely for any signs of infection. We want to observe appropriate isolation if that's applicable. Avoid any sick contacts. Immunizations, vaccines. These kids should definitely receive their vaccinations on time. Anybody with congenital heart defects should get prophylactic antibiotic prior to dental procedures. And again, we just want to be aggressive in taking care of these kids when we think they do have an infection. So we may be getting cultures of different things earlier and trying to be more on top of that. Frequent assessment is always a good idea. Again, listen to the heart. We've talked in class before about how there's kind of this. Sometimes when you go into facilities, you see nurses running around without their stethoscopes and maybe not as focused on patient assessment as they ought to be. Because they have a million other things to do, because they're more focused on computer charting, or because they're lazy, whatever the case may be. Please don't be that nurse. Be the nurse that carries your stethoscope, that assesses your patients like you're supposed to. Again, you may be the person who picks up on a heart murmur that can lead to a diagnosis of a heart defect that nobody knew the patient had. So be that person. Don't be the one who misses it like everybody else. Anything we can do to minimize stress on the heart, we already talked about that a bit. Fevers, obviously having a fever causes a lot of extra stress on the body and the heart, so we want to treat those fevers quickly. Whatever we can do to help the kid rest as much as possible. We've talked about morphine, right? If there's any kind of crisis that involves increased myocardial oxygen demand, we can always try to lower that with morphine. Long term, of course, we don't want these children to live in a bubble. We want them to be active and have normal childhoods. So this is more like acute phase. We want to try to make them rest and keep them as stress-free as possible. But in the long run, as they grow up, obviously we want them to have normal lives. So activity as tolerated would be the better statement for a long-term situation. We're going to be giving these kids IV fluid probably if they're not able to feed well enough to stay hydrated. What else do we do to decrease myocardial workload? Think about patients with high blood pressure and heart failure. Adult patients with high blood pressure and heart failure, we've already talked about diuretics. We've talked about low sodium. What other kind of medicines are these people on? Beta blockers, right, to decrease the heart rate, decrease the myocardial workload, potentially calcium channel blockers. If you have a patient in heart failure, what are some medicines that adults with heart failure take sometimes? Digoxin, digitalis, right, to increase cardiac output. All those things you may see these kids on if they are in heart failure. Remember I said the treatment of kid heart failure is just like the treatment of adult heart failure. So think of your old people in heart failure, and that's what you're going to be doing for your young people with heart failure also. Why would you give a vasopressor? What do vasopressors do? They increase the systemic blood pressure, right? They increase the systemic vascular resistance. So think about a situation like the tetralogy of Fallot, right? Where our goal in putting the patient in that knee chest position is to increase the systemic vascular resistance. Well, hey, you could do that with a vasopressor also. So if you have a situation where there's a right to left shunt, one way that you could, let's think about that heart again. So blood should go from high pressure to low pressure. So if you have a right to left shunt where the pressure on the right side is higher than the pressure on the left side, one way you could try to correct that would be to increase the pressure on the left side. So we talked about doing that with the knee chest position. You can also do that with vasopressors. So these are the things that we've been practicing doing calculations for, right? Dopamine, dobutamine, norepi, etc. That would be another way that we could potentially address that right to left shunt. Tylenol for fever, just like any other person. Please remember the medicines that we use to keep the ductus open or to try to close it based on the situation. NSAIDs cause the ductus arteriosus to close. So the example is indomethacin. Prostaglandins, use those to keep the ductus arteriosus open when we want it to stay open. The example is alprostadil. Okay, that's kind of a lot of information in a short time. Please let me know if anything's confusing about that. If you have any questions, anything like that. I'm going to play these case studies that are just from YouTube videos.
Case Study: Congenital Heart Defects by Patricia Lincoln.
Hello, my name is Trish Lincoln. I'm the clinical nurse specialist in the cardiac ICU at Children's Hospital Boston. What I'm about to present is a case study with questions and answers.
James is a 4-week-old diagnosed at birth with tetralogy of Fallot. He was scheduled for surgery in 2 weeks, but because of hypercyanotic spells, he is admitted to the intensive care unit from the emergency room. Question 1. As James's nurse, you know that tetralogy of Fallot is a combination of which 4 defects?
All right, so what are our 4 defects that we talked about with tetralogy of Fallot? That would be the ventricular septal defect, overriding aorta, pulmonary artery obstruction or stenosis, and then right ventricular hypertrophy. Boom. Bring it, Trish.
The correct answer is ventricular septal defect, pulmonary stenosis, overriding aorta, and right ventricular hypertrophy.
Question 2. The hypercyanotic spells that James is experiencing are primarily related to?
The correct answer is pulmonary stenosis. The greater the amount of obstruction in the pulmonary outflow tract, or the greater the degree of pulmonary stenosis, the more cyanotic the patient will be.
Because blood is unable to flow from the right side of the heart to the lungs to receive oxygenation, the blood will shunt right to left across the ventricular septal defect and return to the body without being oxygenated.
So that makes sense, right? The worse the obstruction in the right ventricular outflow tract, the more likely the patient is to be cyanotic, or the more cyanotic the patient will be.
Question 3. What causes hypercyanotic spells?
These are also referred to as TET spells, right? In a patient with tetralogy of Fallot, like our case study here.
The correct answer is an increased oxygen requirement together with increased resistance to pulmonary flow.
Question 4. If James were to experience a hypercyanotic spell while in your care, your first intervention would be to?
The correct answer is place James in a knee-chest position and administer oxygen. Place the child in a knee-chest position, lying the child down and bringing their knees bent up to their chest. In doing this, the large muscles of the legs contract and force more blood back to the heart. This increases preload on the right side of the heart and possibly forces blood to the spasming right ventricular outflow tract. That same large muscle contraction increases afterload on the left side of the heart, making it more difficult for blood to shunt right to left in the heart. Morphine may be administered to relax the patient and hopefully relax the right ventricular outflow tract.
Question 5.
Preload and afterload are terms that I've kind of tried to stay away from just to avoid confusion. If you hear that, preload is kind of like how much pressure is in the heart, like how much pressure is coming back into the heart from the body. So like how much pressure there is in the heart before it contracts, and then the afterload is the pressure that the ventricle is pressing against. So we think of systemic preload as kind of being the right side pressure, and afterload as being the left side pressure, like the blood pressure. So afterload is what the heart is pushing against. Preload is what the pressure when the heart is relaxed. That's a good way to think of it.
Other clinical signs and symptoms of tetralogy of Fallot include?
The correct answer is chest radiograph showing decreased pulmonary markings, electrocardiogram with right ventricular hypertrophy, and a systolic ejection murmur.
Okay, obviously I don't expect you to be able to pick this out on an EKG or an X-ray, but it makes sense if there is less blood flow into the pulmonary vasculature. You're not going to see lung markings on a chest X-ray. You're going to see a right ventricular hypertrophy pattern on an EKG. Again, you're not expected to be able to recognize that. And then the murmur, like we talked about. And here's an audio sample, maybe.
James undergoes.
Okay, let's go back to that a little bit. I like heart murmurs. So in that situation, you have the lub and the dub happening, and then there shouldn't be any noise between those two things, right? When the valves slam shut, depending on which phase of the cardiac cycle you're in, there shouldn't be backflow in those valves, or there shouldn't be any flow going on when the valves are closed. So if you listen carefully, and this is I think too fast, but if you listen carefully, you can hear the lub and the dub, boom, 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 and in between you hear this. You should not be able to hear that. That is a heart murmur. So let's listen to it again.
Hypertrophy and a systolic ejection murmur.
So again, just focus on the space between the lub and the dub, and that's where you're hearing that little murmur.
James undergoes surgical correction of his tetralogy of Fallot, including a ventricular septal defect closure and right ventricular outflow tract patch. Intraoperatively, a transthoracic pulmonary artery catheter is placed. Before James had his pulmonary artery line removed, right atrial and pulmonary artery saturations were measured. The right atrial saturation is 72, and the pulmonary artery saturation is 95. Question 6. What might this indicate?
The correct answer is a residual ventricular septal defect, which is evaluated by checking right atrial pulmonary artery saturations for an increase in the pulmonary artery saturation. This concludes our case study.
So that sounds like a good thing, right? Oh, higher saturation is better. But remember, between the right atrium and the pulmonary artery, there should not be any way for the saturation to get better, right? Why would the saturation get better between the right atrium, right ventricle, pulmonary artery? The only way the saturation should get better is by sending the blood to the lungs, right? So that indicates that you have some kind of abnormal communication still between the right and left side. So in this case, still have a ventricular septal defect a little bit, which they said they put in a closure device, right? So maybe that means the device was the wrong size, or there's leakage around it, or I don't know. But somehow you still have blood flowing from the left to the right that's making the saturation greater in the pulmonary artery when it should not be.
Please help us improve the content by providing us with some feedback.
All right, there you go. You're welcome to email openpediatrics@childrens.harvard.edu if you want to give Trish and crew some feedback there. All right, let's try this next one. So we've been talking about pediatric patients. This particular presentation from Mayo is about adult congenital heart disease cases. I may not play the whole 24 minutes of this. We'll see.
So again, I have no disclosures. So let's start with the case. This is an 81-year-old woman. So this is definitely an adult with congenital heart disease. No, they're not even in the gray zone here. She came to me with a very difficult to control hypertension. She was on multiple drugs without good control, and she had clear HFpEF, a significant dyspnea on exertion.
HFpEF is heart failure with preserved ejection fraction, as opposed to HFrEF, which is heart failure with reduced ejection fraction.
Edema. She was pretty miserable. She actually really said, I can't even get out of bed and do much. Now, she did have some arthritic components, which she was sort of blaming for that. She said, when I try to get up and walk, I just feel really weak and my legs really bother me. So she'd become more and more sedentary, which was just a snowball effect. So she was unhappy. Her daughter brought her in, and nobody was liking where she was in life. And so, interestingly, she had had surgical repair of a coarctation at age 13, 1950, so very early days of cardiac surgery, though we know that coarctation was actually the first congenital defect that we really did a good repair job on early because we're not doing intracardiac repair. So she had had that and really hadn't had much congenital follow-up. So that's going to get to my point that coarctation is one of the congenital defects I worry about most because patients and their families are told that this is a very simple congenital defect. There's this narrowing of the aorta. We just cut it out and stick it together, or we put a graft in there and you're cured. Cured. Okay. So here's her physical exam. She had a differential in her arm blood pressure. I don't have a good leg blood pressure to tell you, but I can tell you there was a radiofemoral delay. So I felt like there was some change in flow to the legs. But she had a 40 millimeter mercury difference to her left arm, and that was related to how her subclavian was affected by her repair. But you can see that she had pretty significant systolic hypertension with very stiff vessels. We got a really wide pulse pressure here. She hadn't, amazingly, was in sinus at the time of my exam, and she had an S4 present, and she had a fairly loud murmur in the left upper chest that radiated to her back. Her lungs were clear at the moment, and she had some edema on the exam. And this was her echo. The echo pictures are not gorgeous for those of you in the echo lab, but I'm up at the arch, and I'm just...
Obviously, you're not expected to be able to read an echocardiogram or know anything about what this is showing. Just, it's interesting. Here you go.
Putting a continuous wave Doppler through, and she's got a fairly high velocity going through the descending thoracic aorta. It's about 3 meters per second. An abdominal aortic Doppler, which is key in the echo lab when you're evaluating a patient with coarctation, it's not classic, but this upstroke is a bit slurred. It should be really straight up and down. We don't see a lot of diastolic forward flow, which is the hallmark you're looking for on a board exam, is where you see this sort of sawtooth pattern slur like this, but this is not completely normal. So I'm thinking that maybe her coarctation is still pretty significant, or has a recurrent coarctation. So her max gradient was 37, that slow upstroke. Her LV ejection fraction was preserved, but again, she has diastolic dysfunction, and we could see that with all of our echo indicators of filling pressure. She has secondary pulmonary hypertension from her HFpEF, RV systolic pressure 57, and her aortic valve was tricuspid. So, she had about a 50% chance or more of having a bicuspid aortic valve, but she did not, and the valve was actually still functioning well.
So don't worry about any of those numbers, really. That tells us that her heart's still pumping adequately. Diastolic dysfunction means like there's too much pressure in the heart during diastole when it's supposed to be filling. But again, this ejection fraction is what makes it HFpEF versus HFrEF. Don't worry about these other numbers. I guess the takeaway here is that there's pulmonary hypertension. There's still too much pressure on the right side.
Or more of having a bicuspid aortic valve, but she did not, and the valve was actually still functioning well. This was her CT. So we got a CT scan, some axial imaging to look at her aorta. I just wanted to show you how tortuous this thing is. She's got this kind of infolding here. It's relatively narrow. And from this one view, you might say, well, you don't know for sure how narrow this truly is. You're picking one two-dimensional slice, and maybe this isn't the smallest amount, but we did do some 3D reconstruction. She had intercostal collateral arteries, which was a sign of still significant hemodynamic coarctation. And when we really looked at this 3D rendering, you can see how tortuous, again, here, there was greater than 50% narrowing of the aorta. So she had severe recurrent coarctation, I thought, and she had symptoms. She was very hypertensive, poorly controlled. She had some trouble with getting a bump in her creatinine when we were trying to be more aggressive with her control, and was just kind of miserable with her HFpEF. So this is not an easy situation. This is an 81-year-old. There is no guideline that tells me what to do for an octogenarian with a recurrent coarctation, and I can't find a 1,000-person trial to see what the outcomes are. But I did think we should investigate her and individualize her medicine. And so we took her to cath just to make sure we weren't being fooled by echo gradients can be off. I mean, I thought we were right and the CT was good. She had a pretty high peak-to-peak gradient measured by cath, 47 millimeters of mercury.
Don't worry about that.
So when we think about treating HFpEF or even HFrEF, what?
I mean, don't worry about knowing that. You don't have to know. This is all just kind of an example case. I don't expect you to know any of these advanced concepts. She's obviously speaking to other like doctors here, so this is really not for us, for nurses. It's just meant to be interesting, okay? If there's anything that is in here that I didn't talk about, you don't have to know it, okay? But it's just interesting, so enjoy this. You're welcome to worry about the patient. I said don't worry about it. I mean, you're welcome to worry about this poor lady if you would like to. Don't think you have to know any of this for the test, okay?
What do we want to do? We want to afterload reduce. We want to improve their blood pressure. You can't get much more better afterload reduction with the medicine than relieving 47 millimeters of mercury gradient. Thankfully, she didn't have much coronary artery disease, and like I said, her aortic valve was fine. So what do you recommend to do? She's failing medical therapy. She's miserable. So I talked to her and her family at great length with, of course, input from my interventional team. We kind of have a team-based approach to this, and we talked to them about an attempt at stenting this coarctation, explaining to them the risk, the potential benefit, and the limitation in our knowledge, especially in this group. So she decided to go for it, and here we are. I just thought you'd like this. Look at how much of a waste there is. So you can tell, and so this, I'm going to need to go back with a high pressure balloon here, but definitely there was a significant narrowing. And then so we come back with a high pressure balloon, another angle here, you're going to see that waist sort of pop out. And I think it looks like a pretty good result, both visually, and then we actually got a really good result hemodynamically.
I don't really know what most of those words mean. I think the little chicken wire looking thing here would be the stent that they have put in the aorta. I don't really know much about what else she's talking about. You can see there's a pacemaker there. That would be the little robot looking thing with the wires coming off of it. I believe the rest of this stuff would be like, that's probably the line that's going into the right atrium. That's probably the PA catheter. I don't know. Don't worry about any of this. It's just interesting.
So I have a little typo here. It was not an 8 centimeter wide stent, sorry, 18 millimeter by 6 centimeter covered stent. We post-dilated with a 25 millimeter balloon, and the post-stent gradient peak to peak was 0. So I was kind of hopeful we had done some good for this lady. Certainly we had taken on some risk of harm in this octogenarian, but we wanted to see if we could improve her. And interestingly, in the hospitalization period, we just kept her overnight, got this CT scan, and things looked good. And she had what we see even in our younger patients. She started having this interesting diuresis post. She had sort of some fluctuations in her blood pressure, which we see in our younger patient population. And we were able, over a course of close follow-up after hospitalization, to get her off of all of her blood pressure meds but one. And this is how she came back to me. This is her right arm blood pressure was 128/80. I'm not saying this is a typical outcome, like this is like a mutual fund commercial or something. This is not predictive of all outcomes, because, you know, her vessels are stiff, but she had a huge gradient, and we did get rid of that. And she was able to she had an improvement in her creatinine. We had her off of all drugs but one. And what was most gratifying is she already said at 4 months, I was really improved. She really improved with her shortness of breath, and she was getting around more because this arthritis pain in her legs had gotten better. And so I think she was really just feeling better, getting sort of better perfusion. I've seen her now. We're now 18 months out, and she is getting more and more vigorous. So we're now 83 years old, and she's walking now, and her quality of life has markedly improved. So I thought this was a good case to just show you that things sometimes don't present like the textbook, and we're not always talking about 18-year-olds when we're looking at this. And just to bring back the point, this is one of the Mayo illustrations that we use in a little booklet that we give our patients, and we're kind of bad about this too. We act like this is this simple thing. We point to the coarctation like, well, this is the problem. And remember, of course, this is a field effect. This is a problem in the structure and formation of the heart that affects all of the cells that came from the neural crest. And so the ascending aorta is changed in its media. It's different. The aortic valve is different. Even if it's tricuspid, it may have increased risk of calcification. Your coronary arteries are different. Your intracranial arteries are different. And this is just the final common pathway or manifestation of the embryologic change. And so I think we need to recognize that coarctation is a systemic illness, a systemic condition that.
So that makes sense, right? She was saying that everything that comes from the same embryological germline or cells could potentially be affected by this. So it's not necessarily just the stenosis of the aorta, but all the other things that came from that same place embryologically could be affected as well.
It has a lot of effects that we need to be cognizant of, and these patients need lifelong follow-up because we do have a lot of issues after coarctation, and unfortunately many of them are silent till they're a disaster. And so we do have like this patient, recurrent coarctation. Certainly if you do an end-to-end repair when the patient is small, remember that suture line, that's not going to grow well. So whatever size the surgeon sutures there, that's going to stay. Certainly if it's an interposition graft, the graft doesn't grow. And so you've got whatever fixed size you had at the time of repair. If you do a more complicated repair, like a subclavian flap, where the surgeon might take some of your vascular tissue from your left subclavian to augment the aorta, that can have aneurysm formation. That's a high risk of aneurysm in that area. But we also have other aneurysm formation that we're worried about in these patients, specifically ascending aorta dilatation. And these are the patients, we talk a lot about the bicuspid valves because it's just such a higher, bigger population. But the patient with coarctation bicuspid valve is at markedly increased risk for dissection and rupture of their aorta compared to just the bicuspid valve patient alone. So we need to be thoughtful of that in terms of how we time our follow-up.
We talked about that, remember, with coarctation, how if there's a big kink or a big narrow spot in the vessel, how everything upstream of that, there's going to be a lot more pressure in the vessel, so they're more prone to aneurysms, ruptures, that sort of thing.
All of these patients are at risk for systemic hypertension, even if they don't get a recurrence because their vessels are a bit stiff. So we need to be on that and treating patients appropriately to guidelines to help them avoid complications of hypertension, including HFpEF. Early coronary disease reported in all the studies of patients with coarctation, and part of it may be that we're giving them another risk factor with hypertension, but the coronaries are probably abnormal. So we need to have a lot of emphasis on other risk modification to avoid coronary artery disease. And then cerebrovascular aneurysms have been shown to be at increased frequency in patients with coarctation. It's a little unclear that they need anything done about them, and the guidelines I'll show you have softened on what we do about that. So here's what we would say for a patient that you might show up in your clinic, previous coarc, they say they're feeling well. What should we do to follow them
You don't have to know this.
appropriately so we don't get to 81 years of age with HFpEF? Well, these patients do need echo, and it's either between 1 to 3 years. I don't say they all need annual echoes, but if they have a bicuspid valve that's not functioning well, they might need annual or even less than annual echoes. So you're looking at their aortic valve, you're trying to evaluate their ascending aorta for enlargement, you're looking back at that abdominal Doppler, which might be your best first clue that something's wrong upstream before you get any axial imaging. I do think anyone that's had a repair needs some type of CT or MR scanning every 3 to 5 years, depending on what you're following, what you're looking at. I think if this is a patient with a subclavian flap and you're really worried about an aneurysm or it already looks aneurysmal, you might tighten that up. If it's a patient who looks beautiful and they're 25 on their first study, you probably don't need to radiate them every year. You might go 5 years without looking again. So you've got to individualize this. I still do look at the intracranial vessels once. The guidelines now have softened this to a 2B indication because while we're finding these small aneurysms, it's not clear that they progress or need intervention, but I think it's reasonable to look one time. In terms of assessing blood pressure control, of course, you want to be looking in the office, both arms. It is good to get a leg measurement as well. Sometimes, though, you need to find out what they're doing when they're active. So if you have a young patient who's being very active, I'll put them on the treadmill and just make sure they're not getting some really exaggerated blood pressure response to exercise. Ambulatory blood pressure monitoring might be helpful in certain circumstances. And then all of these young patients need, she's not young, but
This is something that we can always do as nurses, right? You can always check blood pressure in multiple extremities and compare it and see if it's off, because it should be, more or less the same throughout the body, right? So if you're getting big, huge differences in different extremities, that tells you something's wrong. Feel free to check blood pressure in multiple extremities anytime.
all of our patients with coarctation need a lipid evaluation and a good discussion about their risk factor modification for coronary disease. So, hope that was an interesting case. And for the last few minutes, I'm going to utilize this case to convey not only some information to springboard to tomorrow's discussion. So here's a 20-year-old woman. She has no prior medical history.
All right, that's probably good for our purposes. If you would like to go back on your own and listen to the rest of this, I played through about 14 minutes if you want to hear the second part of this person's lecture, but I don't think it has as much to do with what we're talking about. All right, one more.
Clinical presentation of congenital heart disease by Nancy Broaddus.
My name is Nancy Broaddus, and I am a clinical nurse specialist in the cardiac ICU at Children's Hospital Boston.
Introduction.
Children with congenital heart disease often present in one of three pathophysiological states. Low cardiac output. This occurs when there is a heart defect that obstructs the flow of blood from the heart or when the heart muscle is unable to pump effectively. Congestive heart failure. This often occurs when there is a heart defect that causes an increase in blood flow to the lungs. Cyanosis. This occurs when there is a heart defect that causes a decrease in blood flow to the lungs.
So remember, a heart defect that does not send enough blood flow to the lungs is going to make the patient cyanotic, right? If it sends too much blood to the lungs, then that's going to eventually lead to heart failure.
Cardiac assessment.
On admission, a full cardiac assessment should be completed. This includes a comprehensive history that should identify if there was a prenatal diagnosis or any significant birth and genetic history. A complete set of vital signs should be done as a baseline, and a set of blood pressures in all four extremities should be done to evaluate for any gradient within the aorta. The physical exam includes evaluation of general color, body temperature, evaluation of heart sounds, and the presence of any murmurs. Assessment of the liver will indicate if there is an overload of fluid on the right side of the heart. And the quality and strength of pulses. Diagnostic tests.
She said assessment of the liver will give you a clue if there's excess fluid or pressure on the right side of the heart. So remember the whole deal with portal circulation that kind of goes straight into the vena cava. And so if there's a backup on the right side of the heart, that can back up into the liver. It could cause liver enlargement. You can get that whole hepatojugular reflex where you push on the liver, which is in the right upper quadrant, and you actually see bulging of the neck veins. So that's what she was getting at there.
Should include a chest radiograph and electrocardiogram. Other tests may include an echocardiogram or a cardiac catheterization.
Low cardiac output.
Signs of low cardiac output in infants and children include pale or mottled skin color, irritability, cool and clammy skin, or decreased level of consciousness, decreased urine output, capillary refill greater than 3 seconds, metabolic acidosis, hypoglycemia, and increased serum lactate. Other signs include weak pulses, temperature instability, or apnea. There may also be evidence of organ dysfunction such as kidney or liver failure. Late signs include hypotension, cyanosis, anuria, and altered mental status.
We're not calling this shock, but what's the definition of shock, or what's another word for shock? Hypoperfusion, right? And if your heart is not pumping, we're not really calling this cardiogenic shock, but it is kind of cardiogenic shock, right? And so you think about what happens in the later stages of shock, these things she's talking about.
Interventions to improve low cardiac output include correcting the heart rate and restoring normal conduction within the heart, administration of fluids, correcting acid-base imbalance and electrolyte abnormalities, and using medications to improve the function of the heart and to reduce the stress on the body.
Congestive heart failure.
Congestive heart failure occurs when the heart cannot deliver enough blood to meet the demands of the body. The heart attempts to compensate by increasing the heart rate, thickening the walls of the heart to contract more effectively, or dilating the heart to increase the volume of blood within the heart to improve cardiac output. Congestive heart failure occurs in 30% of infants and children with congenital heart disease, and occurs in over 75% of children with complex heart disease. The causes of congestive heart failure include volume overload of the heart, pressure overload of the heart, and heart muscle dysfunction. Some of the clinical signs of congestive heart failure include tachypnea, retractions, nasal flaring, diaphoresis, pulmonary edema, irritability, change in responsiveness, fatigue, poor feeding, failure to thrive, tachycardia, cool skin, decreased urine output, an enlarged liver, periorbital edema, pulmonary effusions, and ascites. Interventions for congestive heart failure include medications such as diuretics to eliminate excess fluid, limiting fluid administration, and improved nutrition to maximize calories. Other interventions include respiratory support to reduce the work of breathing and temperature control.
Cyanosis.
Cyanosis occurs when neonates are unable to tolerate the changes that occur when the blood flow within the heart changes after birth. Cyanosis may also occur in infants and children with congenital heart defects that cause a decrease in blood flow to the lungs. Cyanosis, respiratory or cardiac. When cyanosis occurs with respiratory disease, the cyanosis usually decreases with crying, improves with oxygen administration, and there are usually signs of respiratory distress. When cyanosis occurs with cardiac disease, the cyanosis usually increases with crying because the demand of oxygen increases, but the body is unable to deliver sufficient oxygen. Cyanosis with cardiac disease does not usually improve significantly with the administration of supplemental oxygen, and the infants usually breathe fast but do not have evidence of respiratory distress.
That's a super useful table there. Just clinically speaking, not necessarily for your exam, but that would be a good thing to absorb if you're dealing with infants, trying to tell the difference between respiratory disease and cardiac disease.
Tests that can help in the diagnosis of respiratory or cardiac disease include a 12-lead electrocardiogram, a chest radiograph, and a hyperoxia test that involves evaluating the oxygen content of the blood with and without supplemental oxygen.
So we talked about that when we did blood gases, right? The PaO2, how we think of SpO2 as being up to 100%, but the PaO2, the partial pressure of arterial oxygen, can go way up. It can be over 100, right? It can be way over 100. So if you put somebody on high flow supplemental oxygen, you should see that PaO2 rise considerably, assuming everything is working right.
Point of clarification.
Hyperoxia test. The basic physiology of the hyperoxia test is that you are going to use supplemental oxygen to distinguish between cardiac and pulmonary causes of cyanosis. Specifically, the way that the test is done is that you obtain a preductal arterial blood gas in the cyanotic patient. So that is typically a radial arterial blood gas to measure the oxygen tension in arterial blood en room air. You then place the patient in an oxygen-rich environment, so that's 100% oxygen for 10 minutes. That can be either via ventilator or via an oxy hood. After 10 minutes of breathing an oxygen-rich environment, you repeat the blood gas preductally, so the radial arterial blood gas, and remeasure the partial pressure of oxygen in arterial blood. Typically, the cutoffs that we use here at Children's Hospital Boston is a PaO2 in your arterial blood of greater than 150 indicates a high likelihood of a non-cardiac cause of cyanosis, such as pulmonary venous desaturation. A PaO2 of less than 150 is very suspicious for a cardiac cause of cyanosis, as a right-to-left shunt cannot be overcome by the provision of supplemental oxygen. To grade it further, we consider a PaO2 of less than 100 very suspicious for cyanotic congenital heart disease, and this should trigger cardiac consultation.
So don't worry about those numbers, but just understand the underlying idea there, right? If you give somebody a ton of oxygen, 100% oxygen for 10 minutes is a lot of oxygen. So if there is something wrong with the lungs, you should be able to kind of compensate for that by giving them a ton of oxygen, right? If there's something wrong with the pump, that's a bigger problem that's going to be harder to overcome just by giving them oxygen. So we're just saying here that if the oxygen saturation goes up appropriately with a ton of supplemental oxygen, that probably means there's not something wrong with the plumbing. There's not something wrong with the heart. If it doesn't go up as much as you would expect, we're thinking more along the lines of a heart defect.
Signs of cyanosis with congenital heart disease include bluish discoloration of skin and mucous membranes, increased respiratory rate and effort, irritability, or lethargy. Other signs include decreased blood flow to the body, decreased urine output, and metabolic acidosis. Long-term effects of chronic cyanosis include an increased hematocrit, thickening of the blood, increased risk of clot formation, clubbing of fingers, and an increase in the release of oxygen to the tissues.
So we talked about the increased hematocrit and the increased risk of clot formation. We think about clubbing in what? Old people with COPD, right? Old people with chronic hypoxic situations. Well, if you're a young person with a chronic hypoxic situation, you can also see that same clubbing. And then increased release of oxygen to tissue. So that means like the body's trying to get more oxygen off of the blood cell than it normally would. So, and that just makes sense, right? If the tissue needs more oxygen, you're going to try to wring more oxygen out of those blood cells.
Interventions to reduce cyanosis include maintaining a high hematocrit to maximize oxygen carrying capacity, and fluid administration to reduce the thickness of the blood. Other interventions include
So we want the blood cells. We don't necessarily want the blood to be so quote unquote thick that they stroke out. So we want a balance there.
Administration of supplemental oxygen Close monitoring for air in intravenous infusion lines is essential to reduce the risk of air traveling to the brain in an infant or child with cyanotic heart disease.
Oh, there's an interesting point. Normally if you squeeze, if you push too much air into an IV line, where does it go? It goes to the right side of the heart and then goes to the lungs, which is not great. But if you have an abnormal communication between the right and left side, you're potentially pushing that air into the vein, but it's going to end up on the left side of the heart, which means it goes up to the brain and causes a stroke. I had not thought about that before. It's an interesting point.
And using alprostadil in neonates to keep the ductus arteriosus open to allow mixing of blood within the heart.
Okay. Those are pretty interesting cases there, or lectures. I guess they weren't all cases. So that's what I have to say about congenital heart defects. If you have any questions, obviously, please email me, get in touch with me, and I'll try to clear up anything for you. I will post a study guide for the upcoming exam. And yeah, that's it. Enjoy the remainder of your weekend, and I'll see you guys next week, probably. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic, or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and
Andrew, here is your reminder. Feed the dog.
Alexa, stop. All right, take a little break. I got to go feed my dog. I'll be right back.